Okay. Hello, everyone. Thank you for joining us today for our Liver Conditions in Crohn's and Colitis Gutsy Learning Series webinar in partnership with the Canadian Liver Foundation. My name is Kate Lee, and I am the Vice President of Research and Patient Programs at Crohn's and Colitis Canada. Before we get started with the webinar, let's run through some technical logistics. This event is being offered in English and French audio. To listen in French, please select Interpretation, which is the globe icon found on the Zoom menu bar at the bottom, and select French language. If you experience technical problems during the event, please try refreshing your website or relaunching the Zoom webinar. You can use the Q&A box of the Zoom menu bar to submit your questions and comments. I would like to begin by recognizing the history and heritage of the Indigenous people of Canada. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. By acknowledging their traditional territories, we show respect to the Indigenous communities and promote reconciliation. Before today's presentation, I would also like to provide a disclaimer. The materials in this presentation are for educational purposes only. They are of general value and may not apply to specific medical situations. Online resources are not a substitute for the personalized judgment and care of a trained healthcare professionals. As I've mentioned, we're happy to collaborate with the Canadian Liver Foundation to bring you this webinar. For those of you who may not be familiar with their organization, their mandate is to promote liver health and reduce the incidence and impact of liver disease by providing support for research and education into the causes, diagnoses, prevention, and treatment of liver disease. As for us, Crohn's and Colitis Canada is committed to finding a cure for Crohn's disease and ulcerative colitis. Through research, education, and advocacy, we aim to improve the lives of children and adults living with these chronic diseases. If you or a loved one are living with liver disease, make sure to check out the Canadian Liver Foundation's Living with Liver Disease sessions to hear from the experts and connect with fellow Canadians affected by liver disease. Scan the QR code on the screen or visit their website at liver.ca to sign up for their upcoming sessions today. And if you're affected with Crohn's or colitis and need support, you can join us for our virtual Gutsy peer support events to connect with others who understand what it's like to live with or care for someone with these diseases. We have several upcoming sessions available in both English and French, including on August 30th and September 12th in English, and on September 19th and October 17th in French. You can register for the next sessions by scanning the QR codes on the screen or visiting our website at crohnsandcolitis.ca/gutsy support. Again, crohnsandcolitis.ca/gutsy support for more updates. If you enjoy our Gutsy Learning Series webinars, you can also register for our upcoming Surgery and Ostomy for Crohn's and Colitis 101 webinar, which is happening on October 18th. This event will be offered in French with live interpretation in English. You can also register to save your spot for our Mediterranean Diet for IBD webinar happening on January 18th, 2024. This event will be offered in English with live French interpretation. A quick reminder that if you'd like to listen to today's webinar in French, please select the interpretation globe icon in the Zoom menu bar and select French. Now let's get started with the presentation. It's my pleasure to introduce our speakers for today's event. First off, we have Dr. Giada Sebastiani. Dr. Giada Sebastiani is a professor of medicine in the Division of Gastroenterology of Hepatology at McGill University, a founding and steering committee member of the Canadian NASH Network, and a panel member in the Consensus on Models of Care in Non-Alcoholic Fatty Liver Disease of the International Liver Foundation. She is also the North American representative in the guidelines of the European AIDS Clinical Society as a member of the liver group. Dr. Sebastiani is the author of 13 book chapters, 250 conference presentations, and 150 journal articles, including in Lancet Gastroenterology and Hepatology, Journal of Hepatology, and Clinical Infectious Diseases. Her research focuses on fatty liver disease, liver fibrosis, and non-invasive diagnostic tools in liver disease, and is funded by organizations such as the Canadian Institutes for Health Research, the CIHR Canadian HIV Trials Network, and us, Crohn's and Colitis Canada. We also have Dr. Tianyan Chen presenting today. Dr. Chen is an associate professor in the gastroenterology and hepatology division at McGill University. She earned her medical degree and completed a fellowship training in gastroenterology, hepatology, and liver transplantation. Her areas of expertise lie in the fields of chronic liver disease, liver cancer, and liver transplantation. Dr. Chen currently serves as the medical advisor for the liver transplant program at the INES at Transplant Quebec. She is also a member of the Area of Focused Competence Committee in Solid Organ Transplantation at Royal College. Next, we also have Megan Hutchings presenting today during our lived experience section. Megan is a Gutsy peer support mentor at Crohn's and Colitis Canada from Saskatchewan. She was diagnosed with severe ulcerative colitis in 2002 at the age of 16 and PSC in 2015. Megan is happily married with 2 wonderful stepchildren and works full-time as an office assistant. In her spare time, she loves to cook, swim, travel, and go for walks with her dog. We are honored to have you all joining us for this webinar. Thank you for your time and for your support. We'll now get started. Dr. Giada, please take it away.
Thank you, Kate. First of all, I would really like to thank Crohn's Colitis Canada and the Canadian Liver Foundation for organizing this amazing series of events. And I'm really honored to be here to speak about liver conditions, specifically in liver conditions in people living with Crohn's disease and with ulcerative colitis. So we were going to start with a poll question. For the audience, how would you rate your current knowledge of liver complications in Crohn's disease and ulcerative colitis from 0 to 10, where 0 is not at all knowledgeable, while 10 is extremely knowledgeable? If you would like to take your vote. Thank you very much. And here you can see the results. So we have a few of our audience who is quite knowledgeable actually on liver disease, but I see that there is a need to discuss together actually about liver disease in this condition. So we hope that we are going to be able to give you some answers with pleasure. Please do not hesitate to make questions for me, for Dr. Chen, and for Megan. So we're going to start the evening with fatty liver disease in people with HIV, with IBD, and really you will see that people with IBD are to be considered a population which is at risk for fatty liver disease. But first of all, we start with the general numbers on these conditions. So fatty liver disease, or also called NAFLD, is the most frequent liver disease at the global level. It is considered the hepatic disease that is the most frequent globally, with the worldwide prevalence of 25 to more updated 35%, 32, 35%. And there is actually an increase expected prevalence of this condition. And what is actually non-alcoholic fatty liver disease? So in general, it can be defined as the presence of fat in the liver. And when you do a liver biopsy, histologically, when we examine the cells or the tissues under the microscope, we can see that actually the cells in the liver are filled with some fat. And this is what diagnosed fatty liver disease. And usually, this is when there is a fatty overload of the liver over 5% of the weight. And this is actually independent on the presence of significant alcohol intake. This can happen completely without alcohol intake. And this is important to be reminded because of course, people and patients can ask non-alcoholic fatty liver disease, I don't drink any alcohol. In fact, this is a condition that happens in people who don't drink a significant amount of alcohol. And then when you look at the two main differentiation within the definition of fatty liver disease, there are two important definitions to be reminded. One is fatty liver or NAFLD, as we can say for everyone, and this is a frequent and benign and non-cancerous condition. However, where we said the liver is really filled with fat. However, in a proportion of patients who have fatty liver disease, there could be a development of an inflammatory condition, which is called NASH, or non-alcoholic steatohepatitis, where hepatitis means that there is inflammation in the liver, and steato means again that there is fat in the liver. Unfortunately, NASH it's not benign and can actually progress to end-stage complications of the liver that we will see together. And now, in this recent couple of years, there is an international movement to change the definition from NAFLD to metabolic associated fatty liver disease, where instead of giving a negative diagnosis, non-alcoholic, instead we would like to give more accent to the important comorbidities, to the important conditions that cause fatty liver, which are mostly metabolic conditions, and we will see this together. Even more recently, there has been a consensus between all the main associations for the liver in the world, the American, the European, the Asian Pacific, also the Canadian Liver Association was there, where actually it was decided that from now on, instead of speaking about fatty liver disease, to avoid the stigmatization, it will be called steatotic liver disease. This, for the purpose of this presentation, because it's a very recent change, we will continue to call it NAFLD and NASH. However, just to make you know that this will change in the next period, and it's already starting changing. So I would like to show you the numbers about when we speak about this condition overall. So we said that about 25 to 30% of the general population in North America, including United States and Canada, have fatty liver disease. About 20 to 30% of people with fatty liver disease will actually have NASH, which is this condition that we spoke before, necrotic with some inflammation and some hepatitis that will eventually can lead to scarring and to cirrhosis of the liver. And if you translate these prevalences to Canada, you can see that we expected that about almost 8 million Canadians may have fatty liver disease, 2 million may have NASH, and also a significant proportion of Canadians may have cirrhosis due to fatty liver disease. So it's really an epidemic, and I call this a tsunami. We are on a beach, this tsunami is coming to us as people, as doctors, as Canadians, and we are trying to understand how we can put an margin, a limit, a stop to this tsunami. In this study that we published as Canadian NASH Network, we actually found that in the next 10 years, the numbers related to fatty liver disease will even further increase. We expect that there will be an increase in 20% in the number of people, in Canadians, living with fatty liver disease, and even more for NASH, plus 35%. And this is even more worrisome. If you can see here, in the next 10 years, we actually expect double the numbers of liver cirrhosis, so liver scarring due to fatty liver, and even need for transplant related to fatty liver disease. So this is really, as I said, a tsunami. And hopefully we are going to be able in all together to put a margin, a limit to this. In this other study that we published, again, as Canadian NASH Network, we also found that healthcare providers, even the healthcare providers, not the people, the healthcare providers actually are not very familiar with fatty liver. 53% of the primary care physicians and 20% of the specialists thought that the prevalence of this condition in Canada is much lower. It's actually half that what instead it is. It is 30% now, and they thought it was less than 15%. So obviously, education is very important, and tonight it's an amazing event, again, to raise awareness about this condition. Which are the most important factors that can cause fatty liver disease? For sure, there is some lifestyle, for example, sedentary lifestyle, also the food, and we will see this together more in details. And also there is some genetics, for example, and we know, for example, that people of Hispanic ethnicity are more at risk for NASH and for cirrhosis related to fatty liver compared to white and compared to black. So there is some genetics. However, it's very important to be reminded that for sure the lifestyle plays a very important role. And in fact, if we look at which are the most important risk factors for fatty liver disease, they are for sure metabolic conditions, what we put within the umbrella term of metabolic. For example, obesity, for example, diabetes, for example, cholesterol, hypertension. These are all conditions that are considered the most important risk factors for fatty liver disease. However, now we move to the world of IBD. My equipe and some other research teams across the world have started realizing that there are also some atypical or special populations that are not necessarily the classic populations of diabetes, obesity, who may be at risk for fatty liver disease. For example, my team has described a very high frequency of fatty liver disease in people with HIV, but also since 2016, we are studying also this condition in people living with inflammatory bowel disease. In this study, with 384 people with IBD, that we actually screened with ultrasonographic transit elastography with FibroScan to see if they had fatty liver and if they had also cirrhosis associated to fatty liver, almost 400 people with IBD, we actually found, and this is back to 2019, where the prevalence in Canada of fatty liver was considered about 20-25%, we found that actually people with IBD, surprisingly, despite being much younger than the classical NAFLD population, they actually had a high prevalence of NAFLD, about 33%, which we found quite significant considering that this is a young population, as I said. And the same for cirrhosis and for fibrosis, for scarring. So why we think this is the case? Well, first of all, in the same publication, we actually looked at which were the factors in people with IBD which were associated with fatty liver disease. For sure, older age, older in brackets, because as I said, this was a very young population, but also BMI. So those, even if the BMI, so the weight of these patients is lower than compared to the classical NAFLD population, still a little bit higher BMI was associated with fatty liver disease. And again, also some parts of the cholesterol, of the lipids in the blood, which are the triglycerides, were also associated with fatty liver in people with IBD. And another important point is that this has been confirmed, our data, by other researchers in the world. Here I can show you a summary of the results of the studies that have been published on the topic of fatty liver disease in people with IBD. And you can see here that the prevalence was about 22.5%. This seems low, but it has to be said that this was across the globe. Also, in some countries where the prevalence of fatty liver is usually much lower. So overall, the concept is that we think that people with IBD may be at a little bit higher risk of having fatty liver disease compared to the general population. Why is that? Here, I want to show you, again, from one of our publications, why we think that people with IBD may have a little bit higher risk of having fatty liver compared to the general population. Besides having, we said already that weight, for example, is also in people with IBD a risk factor for fatty liver disease. But there are some specific risk factors that don't exist in the general populations, and here are underlined with these two red arrows that you see. For example, people with IBD obviously use lifelong some medications, and we know that the liver is the chemical central of our body, so obviously all the medications are metabolized pass through the liver. So for sure, the use of these medications can have some effect on the liver, and also sometimes the use of total parenteral nutrition. This is also a risk factor for fatty liver. And on the lower side of the graph, you can see that there are also some IBD-specific factors. For example, there is oxidative stress, bowel resection, and also the inflammation related to IBD. So there are some unique risk factors that make these people more at risk, probably for fatty liver and for fibrosis and cirrhosis. Something that it has to be underlined is that in people with fatty liver disease, the number one cause of mortality is not liver disease, but it's cardiovascular disease. And there is also an increased prevalence of some malignancy, of some cancers that are not related to the liver. For example, breast cancer, pancreatic cancer, and so on. So because of this, it's important to consider fatty liver as a systemic disease that can affect many organs in the body. And the guidelines recommend, for example, in people with fatty liver, to do risk stratification, so to look for the cardiovascular risk of this in these patients. Because of that, again, fatty liver has to be considered a systemic disease, a general disease that can affect many organs. And we already spoke about several of them. And the approach as a multi-stakeholder, so multiple specialties, is very important. So here we actually demonstrate the same also in people with IBD in terms of the association of fatty liver. For example, we found in our study that those with fatty liver and IBD had higher prevalence of cardiovascular disease and also higher prevalence of kidney disease, which has also been described in the general NAFLD population. And again, here, a study that we just published in Crohn Colitis 360 from the Crohn Colitis Foundation, again, we found that, again, in 400 people with IBD, we found that those with fatty liver by ultrasound, by FibroScan, actually had higher cardiovascular risk. So again, it's very important to know if a person with IBD has fatty liver, and especially if it has fibrosis, scarring, because this can affect the cardiovascular risk and so other problems. You can see here, for example, another way to show this is that those people with fatty NAFLD, you can see they have higher cardiovascular risk compared to the people with IBD but without fatty liver disease. And same story for liver fibrosis, so for liver scarring. So again, this is again the study that we just published, where you can see that fatty liver was actually an independent risk predictor, an independent risk factor for cardiovascular disease in people with IBD, together with the duration of IBD and with ulcerative colitis. So how we can diagnose this disease? It is very important to know that fatty liver, usually NASH, can be diagnosed just with histology, with this sample. However, we have some non-invasive tests to diagnose the fat in the liver and also the fibrosis, so the scarring. And I would like to show you this. These are all either biomarkers, so with a simple blood test, we can do a staging of the fibrosis of the scarring, or with the fibroscan that you see here, we can actually look at the fat in the liver and also if there is scarring into the liver. So a very simple device, a very simple fibrosis test and steatosis test with an ultrasound, you can have an idea. And here, this is an example of a biomarker, how it works. With the blood test, we calculate through age, platelets, and the liver transaminases. If this FIB4 is less than 1.3, the risk of having liver fibrosis due to NASH is very, very low. It's less than 5%. So this is a very simple test that primary care physicians can use to diagnose if there is scarring into the liver of people with IBD, for example. Here, these are the new guidelines that have been released by the American Gastroenterology Association, where they actually use the FIB4, this simple biomarker based on age, platelet, and liver transaminases. And if only this FIB4 is not able to exclude the presence of scarring in the liver, then the patient will undergo some ultrasound with this fibroscan that I mentioned to you, which is a simple fibroscan, simple ultrasound. So I would like just to pose another poll, if you like. So which of the following non-pharmacological, so non-medication methods can be used to manage liver disease in your opinion? Is it weight loss? Is it exercise? Is it diet? Is it bariatric surgery? Or is it all of them? So if we would like just to have an answer to this poll, then we will see together the rationale beyond this question. Amazing. So yes, so here I see that the answers are, in most of the cases, actually it was all of the above, which is the right answer. So amazing. So I hope you will still learn something from the next part of the presentation, which really targets what we can do for fatty liver. We actually saw together that this is a very frequent disease, and especially in people with IBD. Can we do something? Yes, there are non-pharmacological approaches, include weight loss. We know that if a patient loses, for example, more than 3-5% of the initial weight, actually you can regress the fat. You can eliminate the fat from the liver. So weight loss with the diet and with exercise really work. I can tell you in my practice, it works really very well. And exercise also. This is also an amazing way to reduce the cardiovascular risk, for example. So we usually say, according to guidelines, to target 150 to 200 minutes per week, divided into 3 to 5 sessions of moderate aerobic exercise, and actually also bariatric surgery when there is the indication. And I know that Kate, before, she mentioned the Mediterranean diet. Actually, the Mediterranean diet is also like the golden mine also for fatty liver disease. There are several studies which show that the Mediterranean diet improves fatty liver disease. Can be adapted to several cultures, but it seems that extra virgin olive oils is an essential element of the Mediterranean diet because it's rich in antioxidants and polyphenols. And here you can see an example of the pyramid of the Mediterranean diet that I always show to my patients. Here, what you can do the most, and here what you have to do the least, obviously. And here you can see the studies really show that those patients who use Mediterranean diet, there was a reduction in fat in the liver. And this was also in BMI, actually, and also in insulin resistance. So it really works. And what about coffee and alcohol? The good news is actually that coffee, according to the guidelines, coffee consumption of at least 3 cups daily is associated with less advanced scarring to the liver. So coffee is a yes. Alcohol is actually a no, especially in people who have fatty liver disease. So this is not a recommendation from the medical standpoint, but coffee is a yes. And here you can see a resume of the intervention, a dietary intervention that we have actually recently published, one of my students. So the diet and the exercise to go from fatty liver to healthy liver. What about pharmacotherapy? Is there any medication to treat fatty liver? And this is the last part of my presentation. So according to the guidelines, you know for sure that you know about this Ozempic semaglutide can be used can be considered to treat diabetes and to treat obesity, as it offers a cardiovascular benefit in patients with NASH. It's not a treatment for NASH yet or for fatty liver, but it can treat the conditions that are associated, like, for example, obesity or diabetes. Pioglitaz is another medication for diabetes. It's recommended. Vitamin E, it's an antioxidant, which is recommended by the guidelines to treat NASH. And then there is, obviously, there is no medication that is yet approved besides this vitamin E. Semaglutide is not yet approved, but we hope in the future that something will come. What about statins? This is very important. Statins should be used very generously in patients with fatty liver because of this increased risk in cardiovascular disease. So the guidelines recommend that patients with fatty liver, they should actually be considered almost always for statins. Here, I would like to conclude my presentation to give you some take-home messages. So I think that really the data epidemiologically at the global level show that fatty liver disease is the most prevalent liver disease globally. It's very frequent. It's the most frequent liver disease globally. Liver fibrosis is the main prognostic factor. So this scarring for which we use fibroscan or a simple blood test biomarker like FIB4 to see if there is fibrosis. So we need to see if there is fibrosis in a patient who has fatty liver disease. Another important point is fatty liver is a multi-system disease. It doesn't affect only the liver, but as you have seen together with me, it actually gives a high risk, for example, of cardiovascular disease and also of extrahepatic malignancy of cancer. And I think that our data and also data from other researchers show that fatty liver disease is actually more complex in terms of the causes in people with IBD. And in fact, no surprise that fatty liver disease, because there are more risk factors for fatty liver, seems more frequent and maybe even more severe, maybe a little bit more scarring in people living with IBD. And there are non-invasive tests to actually look for scarring, at least in people with IBD in general, for people at risk for fatty liver disease. For example, FibroScan, this biomarker with the blood test FIB4. Current approaches include lifestyle modifications like the Mediterranean diet and the exercise, coffee, and some pharmacological options. Newer treatment that we hope they will arrive in the future may include Ozempic, GLP-1 agonists, and other molecules that are currently studied. So I would like to introduce now my co-speaker tonight, Dr. Chen, and thank you very much for listening to me and for your attention.
For the excellent presentation on hi guys, my name is Tian. I'm just going to go ahead and share my screen so you can.
Dr. Chen, you're breaking in and out. I wonder if you can put your mic closer to your mouth, or if not, perhaps you will have to call in with your phone.
Is it better audio right now?
Yes, you may have to keep the mic close to your mouth.
I'm going to increase the volume to the max, and you guys can let me know if so far so good.
No, you're breaking in and out.
About now?
Now is fine, but if you continue talking, sometimes there's periods where we can't hear you. I wonder, are you able to dial in?
I am on the dial-in mode.
Oh, you are.
right now. This is unfortunately, the best would offer with the limitations. So I would
I
apologize for
wonder,
that. And
Dr. Chen, instead of using your headphone, could you just try using without your headphone? Maybe that'll help. Are you
I
able
could try that
to?
as well. Yes, I can.
Yes.
Is it better now?
Yes, much
Oh,
better.
okay, I shall do that. Is my voice very loud, like I'm screaming,
No,
or this is
no,
okay?
it's perfect. Thank you.
Okay, perfect. Thank you. I apologize for the technical difficulty, and thank you for bearing with me. So following Dr. Spatani's talk on a very common liver disease, we'll switch gear a little bit to talk about primary sclerosing cholangitis, short for PSC. This is a very uncommon liver disease, but especially affecting patients living with IBD. So we'll be starting with what is PSC. I will just make sure you guys can see this part. So I wanted to share you guys with the slides over here to say this is a chronic patchy liver disease, and the primary segment, what the department within the liver that's affected are the biliary trees or the bile ducts, which are green on the screen over here. And the disease can be affected any part within and outside the liver, including small, medium to large size bile ducts. Usually what happens is there's inflammation within the bile duct, which we're referring to as cholangitis. Chronic inflammation, like we see before for fatty liver, will lead to scarring, which we're referring to as fibrosis. And the focal scarring will eventually lead to narrowing or difficulty in the flow of the bile duct, which can sometimes cause a blockage, increase the risk of infection, or stone formation. So it's really what I refer typically to patients as the plumbing of your liver that's affected, patchy, and is a chronic process. So how common it is in PSC? So we did talk about it. I was alluded to that it's relatively uncommon, certainly very, very uncommon compared to the common fatty liver disease you just heard. However, it is reported the most commonly seen new cases diagnosed every year in North America and Northern Europe. And Canada, with a high cases of IBD, will also see relatively more cases of PSC as well. Depending on the literature we're looking at, the number of existing cases and new cases accumulating being reported are anywhere ranging between 1 in 10,000 to 1 in 100,000 patients per year. So it's quite rare compared to what you just heard, like up to 30% of the population may be at risk for. It's a rare liver disease, indeed. So this condition does not discriminate gender or age. It can affect both males and females, and it can affect anybody from any age, from pediatric population to elderly population. It is very commonly associated with inflammatory bowel disease. Do not need to have inflammatory bowel disease to have the diagnosis of PSC, but once you have PSC diagnosis, eventually the majority of the patients who are affected by PSC will develop inflammatory bowel disease. So as a liver physician, we're constantly looking for symptoms of our inflammatory bowel disease for patients who have not been diagnosed with it yet. And often, just like many other autoimmune conditions that tend to cluster together, it can present with more than one forms of autoimmune liver conditions within the liver, and PSC is only one of them. The rarest one, but one of them. The natural history of the disease is very variable and often very difficult to predict. I think it really comes from two things. One, we still have a lot to learn about PSC and how it's affecting our patients. And two, this is a very rare condition, so we don't have a lot of patients to observe over time, so there's a lot of variabilities. Like I said, the primary segment or department of the liver that's affected is the bile duct, which is the plumbing of the liver. It really depends on what's the percentage of bile ducts that's affected, and are they mostly large bile ducts or small bile ducts, to dictate to see if you have symptoms or how sick you are over time. For the most part, when people have a lot of bile duct affected or large proportion, especially the larger bile duct, for example, here I listed here as common bile duct, that's where patients tend to have a lot more symptoms, tend to get into trouble. One thing I want to make a note is I get this question quite often from patients and their colleagues, whether somebody who's already have a diagnosis of IBD, whether Crohn's disease or ulcerative colitis, whether the IBD is very well controlled or very active does not really affect the progression or the future of your PSC. So even though they're both autoimmune conditions, they're linked in terms of some of the pathophysiology possibly, but their evolution are completely different, and the treatment of one does not necessarily affect the evolution of another. So it's really two different teams that are looking after you for your liver and your digestive system. In terms of what could happen over time with the liver, the first one is the two that are quite common. We see the first one, I go back to bile duct all the time, is when there's a blockage or sluggish flow in the plumbing of the liver, and you can have an infection because there's a blockage. When that happens, that's a serious condition because any infection can be quite serious that needs immediate medical attention. Over time, this is a chronic liver disease. Like any chronic liver disease that we've seen so far, and fatty liver is one of them we see, and patient can develop severe scarring, fibrosis, and cirrhosis, and liver failure, another complication related to liver failure and end-stage liver disease that Dr. Spassani alluded to. In particular, patients who are co-affected by PSC and IBD have increased risk of colon cancer. And as a liver doctor, the one that we get a lot more conscientious, we're very proactive for the surveillance really for bile duct cancer, which we'll talk about a little bit more later on, which is rare cancer within the liver. And in general, it's unfortunate patients who have a confirmed diagnosis of a PSC does appear to have a higher mortality risk compared to the general population. And most of this mortality risk is because of the cancer risk that's more elevated. And we'll talk about the screening in a later section today. So I do have a question here. The question for you guys to pull is to ask, do the scientific findings currently suggest that having a family member with PSC does increase the chance of PSC or not? You have the choices of yes, no, or I'm not sure. So go ahead. I see so it's about half of the audience is not sure. The remaining, most of them are thinking maybe it is a relative risk. That's a good guess because that's what we say often for IBD patients. Let me just move forward the slide. So that brings us to risk factors and some of the causes I want to talk about. As we alluded to, it is an autoimmune liver condition, but we don't really understand very well exactly leads to PSC. From somebody who does not have PSC, P really stands for primary, which means we don't really know the exact cause. We suspect very similar to some of other autoimmune conditions that are involving the digestive system, it's a combination of coexisting factors that involve genetic factors, environmental factors, and certainly the damaged gut barrier due to the imbalance of gut microbiome that you guys might have heard about it from other sessions, which is particularly pertinent for people who have IBD. So far, the data does not support that the fact someone has a family history of PSC, that on its own is a risk factor for PSC for their family member, or the fact that you may have been diagnosed with PSC automatically increase the risk for your family members for PSC in them. That's not the situation right now. So symptoms and signs for PSC, we've talked about it a little bit before. So they're largely non-specific when it comes to chronic liver disease. It could be fatigue, abdominal pain, fever, and itchy skin sensation. Itchy skin sensation is a lot more common in patients who have plumbing problem of the liver, in this case of PSC, and often patient may also experience anxiety and depression. Things that are a lot more specific in terms of the plumbing system are combination symptoms. Jaundice, which means the yellowing of the skin, that's depicted over here. When you have a combination of yellow skin and itchy sensation, or yellow skin and right upper quadrant pain, that's where the liver sits, or fever, those are suggestive of potentially sluggish bile flow or even blocked bile duct, which put you at risk for infection. Those are the reasons to reach out to your health providers and seek for medical attention. And those are some of the early symptoms that get picked up when your physician or doing routine checkups, they pick up early signs of PSC. At the time of the diagnosis, only 50% of the patients, so it's like tossing a coin, only half of the patient will, on recollection, will say, oh, I think I have the symptoms that are suggestive of the bile duct problems or intermittent. So really, largely, it could be very silent disease. Among those who does not have symptoms at the time of diagnosis, because they were diagnosed by a number of modalities that we'll discuss later on, half of them eventually will develop symptoms in the next 5 years. But 1 in 4 patients who has diagnosis of PSC will not develop symptoms for many, many years to come. So really relying on routine testing and follow-up. The ones who does not have symptoms does not mean they tend to have an easier course or disease category as well. So what are the signs? How do we pick up diagnosis of a liver problem, PSCs? So for the situation of PSC, there are 2 modalities that we're relying very heavily. The first one is routine blood testing. We'll test for liver testings. The second is really to try to visualize with imaging tests what the bile duct looks like, or the biliary tree, which is referred on the slide. There are a number of modalities. You may have had some of the tests down already for your IBD or other health conditions, which includes ultrasound, CT tomography, which is a CT scan, magnetic resonance imaging, which is MRI, and direct visualization of the bile duct. Those are more invasive testing, the last one, which we typically do not do upfront. So to be more specific about diagnostic testing, we'll start with the blood test first. One, I'm referring to routine blood tests. These are blood tests that healthcare, like primary health providers, will ask. So these are not to access extensive blood tests. Those are routine blood tests, much as people test for kidney function, for diabetes, and for cholesterol. Very, very accessible blood tests. And we're really looking at 2 liver blood tests specifically. Those are elevated liver enzymes, which are proteins produced by the liver when there's stress happening within the liver. The 2 tests we look more specifically are alkaline phosphatase, short for ALP, and gamma GT, which is GGT. These are more specific to inflammations or potentially injuries of the bile duct, which is depicted here in green, for liver over 6 months. And sometimes patients will have an elevated bilirubin, which gives the yellow appearance of the skin, but not always. Classically, we'll find patchy or scarring tissue that we see that's most appreciated on the MRI testing, which is the preferred testing due to the lack of radiation. So there's no radiation exposure, and also it's non-invasive. Usually it's a combination of the Takehome blood test plus the imaging. So that's most of the time how we confirm the diagnosis after we make sure there's no other infectious liver disease or immune liver disease, mostly by blood tests. We do not recommend liver biopsy as a routine diagnostic testing for 2 reasons. One, it may not be needed to have sufficient diagnosis when the imaging is very typical and the blood test is very typical. 2, like I said for the first slide, this disease, the process is very patchy. So when you do a liver biopsy, you only sample a very small tissue, and it's entirely possible that part of the liver is completely normal. So the fact that test is negative on the liver biopsy does not exclude diagnosis of PSC. And often it's an invasive testing, it can cause pain and other complications. Unfortunately, there are no good blood tests that are autoantibodies that we can offer to patients to say, you most likely do not have PSC or you most likely have PSC. It's really routine blood tests plus the MRI that's really the preferred testing for diagnosis. So here I share with you a diagnostic algorithm that's published by the the latest guideline updates by the American Society of Liver Disease is one of the leading societies for study of liver disease. So often, like we refer to, if there's physical exam or symptoms, and routine blood test leads to suspicion of PSC, the next step is really a high-quality bioduct imaging, in this case the MRI. If they're typical strictures, we have the confirmation. If the findings is atypical, typically it could be referred to a tertiary care center where they have more experience, or repeat the MRI or the liver biopsy later on. If the test is normal, depending on the situation, sometimes patient got referred for liver biopsy and then take it from there. Here, there's a mentioning of small PSC, which is the 10% of the patient. Very, very uncommon. We see them almost exclusively in patients who have already diagnosed with IBD, and in which case we mean that the blood test shows there's inflammation, but the MRI is normal because they're so small, then we rely on liver biopsy, but it's very uncommon, this particular diagnosis within already a less common disease. So after spending time talking about how rare this disease is, how non-specific the symptoms are, and we do have pretty good diagnostic tools, what are you expecting in terms of what we can offer you in terms of symptom and treatment management? So I wanted to start with symptom management, which means we have tools to help you to feel better, to have a better quality of life living with your disease, but does not necessarily modify the future or the natural history of your disease. So the first one that I mentioned was quite specific and quite common in patients who have itchy skin, and the technical term we're referring to are pruritus. Is really related to the inflammation, the sluggish flow, sometimes the blockage of the bile duct. First of all, we always want to make sure there's no physical blockage, because that's where we need intervention, immediate medical attention. When that's not the case, there's a list of things we could offer you. We always recommend the non-pharmacological interventions first, which are avoiding heat, use good moisturizer, and antihistamines are any seasonal allergy as antihistamines you can get over the counter are safe, often quite effective. And lower down here, I listed a number of medications that are often prescribed by our healthcare providers. You need a prescription for that. And some of them may need a bit more monitoring to make sure your liver is tolerating them well. And none of them has issues with IBD medication or affecting IBD symptoms to our knowledge. Lower down in the slides, you see that there are a lot more advanced or specific treatments. Some of them are very, very dramatic, such as replacing a whole new liver for symptom control. Those are really exceptional situations. Fatigue, again, is very common in patients who suffers, unfortunately, from this condition. Often the first thing we do is to make sure there's no other reasons that people are feeling the fatigue that we can reverse and intervene more effectively. We make sure there's no thyroid problems, there's no sleep apnea, and there's no depression. Most of the tools that have been studied to show very moderate efficacy in managing fatigue for patients who are affected by PSC are mostly lifestyle modifications, regular exercise, meditation, and sleep hygiene. So are not very different from what you may hear from your IBD doctors for fatigue related to IBD. Again, like I said, these are two things. You have your IBD, and then you have your liver disease, in this case, the PSC. So the management of IBD and PSC are parallel. They're in conjunction. They're not in conflict. So we always want to make sure that if you do have diagnosis of IBD, you need to see your IBD doctor to be followed. If you do not have any diagnosis, we'll ask you for symptoms and survey regularly to make sure we're not missing them. Patients who are affected by PSC, largely, if they don't have severe liver disease, which is the majority of the case, it should not negatively affect fertility and pregnancy and parenting. One thing we do monitor at diagnosis on the irregular interval are really nutritional and metabolic bone disease, because when you have a sluggish bile flow, some of the vitamins may be affected in terms of the efficacy of the absorption. And over time, one of them is vitamin D, so that could affect the bone health. So we do screen for poor bone health, and patients sometimes get advanced recommendation for calcium vitamin D supplements. So it's really to make sure that the nutritional status is well supported. So these are the symptoms. The only treatment that has been consistently studied that showed potentially helping is ursodeoxyl acid, short for UDCA. It's a medication that we commonly use for liver disease, especially for bile duct inflammation. It may be considered in those who have elevated liver enzyme that was alluded before, but high doses seem to have potentially negative impact on patient outcomes. There are many, many other modalities, agents being studied, antibiotics, corticosteroids, biologic immunosuppressions. Every single medication you could imagine or heard that have been studying IBD have been studied probably in PSC. Unfortunately, up to date, there's not a single medication that's been shown consistently in a rigorous trial session to be changing the natural history of this particular liver disease. Therefore, there's nothing approved in North America right now that your doctor can say, please take this medication, and this is going to slow down the disease progression. It's preventing the liver, preventing potentially getting sick, to the point that the latest American guideline actually recommended for every single patient with PSC, we should offer, if we can, the option to consider for clinical trials to give them potentially early access to potentially medication that may be helping them. But really, largely what we would offer are helping you living with your symptoms better, and we don't have a lot of effective tools that you may see for IBD that will actually reverse inflammation, reverse scar tissue that's happening in the liver related to PSC. The other very important aspect is really to make sure there's no infection when there's a blockage, because that could be life-threatening, and to monitor for the degree of liver damage that Dr. Spassani and my colleague referred to for fibrosis. So the assessment tools that she mentioned before applies very similarly to PSC as well, because it's another chronic liver disease. We tend to treat that as well. A very, very important component that we monitor is really rely on non-invasive testing, which I listed here: blood test, liver fibrosis, which is testing for liver scar tissue that you can do with a blood test or imaging, and regular intervals to look at the bile duct to assess the degree of damage. And then we want to make sure that nutritional status, especially bone health, are well maintained and verified. The very key component that we have as a liver doctor is really to make sure that we monitor the inflammation, the liver damage, and the effects of the liver disease potentially outside your other organ system. And we wanted to see how we're doing, that we can do to help you to cope with the symptoms that may be affecting you that are quite non-specific sometimes, but nonetheless very debilitating. And to make sure we have an open mind to think about other liver diseases might come along. The fact you have a PSC diagnosis at the beginning does not mean you will remain having the same diagnosis for the rest of your life. That some of you may have seen with your IBD diagnosis, that your diagnosis took some time to have a final diagnosis. One of the most important part that we spend a lot of the time as a liver doctor is to survey for potential cancer complications very specific to this disease. The one I want to spend time to talk about it is this so-called the bile duct cancer, because it's the main cancer that's affecting our patients that really is the main driver for people who pass away at an earlier age compared to the general population. So inflammation in the bile ducts puts you at risk, or puts somebody who is affected with PSC at risk for liver cancer. And the lifetime risk ups up very significantly, so the age of diagnosis does make a difference. So that's why we're very, very heavy on direct high-quality visualization of the bile duct. In this case, it's really the MRI that's preferred. And we also do tumor markers. They're not very good on its own, but in combination with the bile duct visualization with the imaging test, it's much better. Right now, it's recommended to do the combination of imaging tests with a blood test for tumor marker at least once a year. Personally, I usually recommend MRI if the patient can tolerate it. The ultrasound is a good test, but it does not see as well compared to the MRI. So if you have access to MRI and you not a terrifying experience to have MRI, we tend to ask for it. It's a specific way to visualize the liver. It's different to the MRI that your IBD doctor may be asking for. So early detection is really the key. Other cancers that are related to the liver are two that we survey very heavily as well with the scan that we just mentioned before. One is really the gallbladder cancer, and we look specific for gallbladder polyps. They're very common in general population, and usually unless they're more than 1 to 1.5 centimeters, which means 10 to 15 millimeters diameter, we tend to remove them because there's a risk of cancer. And when we remove polyp on the gallbladder, remove the entire gallbladder. It's different from the colonoscopy. But for patients who are affected by PSC, we do not wait for the polyp to get bigger than 8 millimeter. Once they're more than 8 millimeter, whether you have one or multiple, we usually recommend that you see a surgeon to consider for gallbladder removal to reduce or eliminate the risk of a gallbladder cancer later on. Primary liver cancer, which is hepatocellular carcinoma, are mostly affected by patients who have severe scarring of the liver with cirrhosis due to PSC, and that's twice a year surveillance, like any other surveillance for primary liver cancer. Colon cancer, I wanted to make a note because it's very, very specific. When somebody has a combined diagnosis of PSC and IBD, regardless how quiescent or how active their IBD is, we do recommend they get their surveillance colonoscopy at least every 1 to 2 years. Ideally every 1 year, but at 2 years is really the lower bar because the presence of PSC greatly increased the risk of a colon cancer, even though the IBD could be very well controlled. In fact, we recommend everyone who have a diagnosis of a PSC without the diagnosis of IBD to have a routine colonoscopy. And often we end up repeating this at a regular interval, typically it's about every 5 years, to proactively look for early signs of IBD because we do not want to miss that cancer risk in the colon. I think after a relatively heavy talk in terms of rare disease, they seem to be more affected patients with IBD, with PSC. We do not have a lot of effective treatment that can alter the future of the PSC at this point yet. So there's all research coming down the pipeline. There's trials going on in phase 2 and phase 3 across Canada, across the world, to look at decreasing inflammation and scar tissue in the liver, specifically for PSC patients. So I do encourage you to talk to your healthcare providers to see if there's any options in your in-capture area to see are there any opportunity to participate. So that is to say that there's light at the end of the tunnel, there's hope down the line, but we don't have anything I can present you at this point to recommend specifically. That's the end of my slides. I'll just a moment to have Megan, who's next. Listening.
Thanks, Dr. Chen. And Dr. Sebastiani for that really informative session. As Dr. Chen said, we now get to hear from Megan to talk to us about her personal lived experience. Megan?
Hi, everyone. As mentioned, my name is Megan, and I'm a peer support mentor with Crohn's and Colitis Canada. I've had ulcerative colitis now for 21 years and primary sclerosing cholangitis for 8 years now. When I was first diagnosed with inflammatory bowel disease, I felt really alone and really embarrassed. I was having abdominal pain, cramping, bloody stools, and I was going to the bathroom anywhere from 10 to 15 times a day. So needless to say, I didn't like leaving my house at all. I was always afraid that I was going to leave my house and not be able to make it to the bathroom in time and end up having an accident in public. So for me, that was always really, really embarrassing. I also felt really alone. I grew up in a really small community, and there was maybe 1 or 2 other people in my hometown that had inflammatory bowel disease. So I couldn't really relate to anyone, especially anyone my own age, because of course I was 16 when I was diagnosed. So I was going through all of the typical teenage issues and then dealing with inflammatory bowel disease on top of that, which made things so much more difficult. And I was actually so sick in my grade 12 year that I had to get permission from the teachers there to get a tutor and to do a lot of my schoolwork from home. And without those tools available to me, I wouldn't have graduated high school when I was supposed to. So I was very, very lucky. I had a very good support system when it came to my school. My first flare basically lasted about 10 years straight. I went through various medications, none of which really worked for me. And then in 2014, I decided that I needed to make some diet and lifestyle changes, and I was finally able to get my UC into remission. Then in 2015, I was diagnosed with the liver disease PSC. I was having a variety of symptoms of the liver disease. So I was having the fatigue, the nausea, the lack of appetite, the extreme itchiness, especially on my hands and my feet, and then pain in the upper right abdominal area as well. And of course, because of these symptoms, my life got a whole lot more difficult as well. With the fatigue, it was a fatigue that I had never really felt before. It didn't matter how much I slept. I was always exhausted. So getting out of bed in the morning was impossible. Staying awake at work was really, really difficult. And then, with the nausea and the lack of appetite, of course, I didn't want to eat anything. So most days I would eat a grapefruit for supper, and that would be it, because that's all I wanted to eat. And then with the itchiness, it made normal, everyday, daily tasks really difficult. Something as simple as doing the dishes and putting my hands in warm water would cause the itchiness. Having a warm shower would cause the itchiness. And the itchiness for me was so bad that I would actually scratch until I was bleeding, and I would actually bruise the next day because I had scratched so much. So I was having all of these symptoms, and then my liver enzymes went extremely high as well. So my GI decided that I needed to be tested for a possible liver disease. So I went in for an MRCP, so an MRI, and then unfortunately that came back as positive for PSC. And I remember sitting in my doctor's office after he was giving me the diagnosis, and he explained to me that I would have to go for routine blood work to check my liver enzymes. So I'd have to go regularly. And then I would also have to go in for procedures called ERCPs. And the ERCP combines the X-ray and the endoscopy. So, on one hand, when I got my diagnosis, I was relieved because I finally had an answer for all of the symptoms that I was feeling. And then on the other hand, I felt really scared. I felt like my life was over. When you're told that you have another incurable disease and that chances are you're going to have a liver transplant because of that disease, that can be really hard to come to terms with emotionally. And I know it was for me. It took me years to feel okay about my diagnosis, and I'm very, very lucky. I have a really good support system. I have a good group of friends. I have a very loving family. And without them, I don't know how I would have gotten through those first years of my PSC diagnosis. And, there are times where I still get upset about my diagnosis, but for the most part, I really try and keep a positive attitude. I've got things that I want to do, and I'm not going to let my diagnoses, either my ulcerative colitis or my liver disease, stop me from doing the things that I want to do, because life is too short and I'm just going to stay as positive as I can. I'm very, very happy to say that I'm currently in remission from my UC. I've been in remission for just over a year now, and I'm currently on Xeljanz, like I said, which has put my UC into remission. And as well, my liver enzymes have stabilized, which is fantastic, because this is the first time in 8 years that they've actually stabilized. So currently I'm just waiting on an MRI. to see how my PSC is progressing. So I'm hopeful that it's going to be good news, but like I said, I just have to wait for that MRI. Over the years, I had to come up with different strategies to deal with my PSC symptoms. The itchiness for me, like I said, was the worst symptom. So I did use a variety of strategies. I've used anti-itch lotions, I've used Gold Bond, and I've used Aveeno. Aveeno has an anti-itch lotion. I think it's more so for bug bites than anything else, but it seems to help me with the itchiness. And then, of course, at night, my itchiness would get worse, and especially on the bottoms of my feet. So what I would do is when I would go to bed at night, I would blow a fan on the bottoms of my feet, and then the cool air would help with the itchiness as well. And then as a last resort, I would take an allergy pill. If the itchiness was really bad and I still couldn't sleep, I would take an allergy pill just to help relieve some of that itching. I think it's really, really important for us to raise awareness about inflammatory bowel disease and liver diseases such as PSC, because I know from my experience, you can feel really alone. And I'm here to tell you that you don't have to feel alone, because likely if you're going through something, there's somebody else that has gone through what you've gone through as well. So don't be afraid to reach out. Don't be afraid to talk to others that have the diseases as well. Just know that you're not alone. And also know that there is hope. Remission is possible, and you can live a happy, healthy, normal life with a liver disease or IBD or both. And you know what? I'm proof of that. So thank you guys so much for listening to my story. I know you guys have busy schedules and you've taken the time out of your day to listen to me. So thank you so much. Take care, everybody.
Thank you so much, Megan. It's interesting how we had Dr. Sebastiani and Dr. Chen speak from a clinical perspective and research perspective, and you brought the human perspective into this. So thank you. It really does give us, the audience and myself personally, a rounded view of what it's like to have liver disease and IBD. And as Megan said to the audience, you don't have to do this alone. For those who might be like Megan, Megan herself is part of the peer support program. And if you feel like you can't turn to your family or friends, please do reach out to Crohn's and Colitis Canada, and we'll do our best to match you with someone who has a similar lived experience and whom you can speak to. And thank you, Megan, for all that advice and tips that you've learned as you've been living with both diagnoses. So with that, I would like to bring Drs. Chen and Sebastiani back on with their webcams. Thank you. It's our Q&A period now, and this is where we will answer, or the panelists, not myself, I'm not an expert here. Panelists will answer questions that the audience members have posed. And so we have already questions that the panelists who registered have posed to the panel members. And so we're going to start with that. And then I'm assuming Lucy will be feeding us additional questions that the audience members might have asked during the session. So we're going to start with the first question. What are the risk factors of liver disease in Crohn's and colitis? And the second follow-up is, which preventive measures can a person with IBD take to lower their risk of developing liver disease? And this is open to Dr. Sebastiani, if you can start the answers.
For sure. Thank you. First, I would like just to congratulate with Megan for a very inspiring presentation. I truly enjoyed it. Thank you very much, Megan. And of course, to Dr. Chen for her presentation on PSC. So for the question, I would certainly answer from the fatty liver disease point of view, because obviously, as we said, as fatty liver is the most common liver disease actually worldwide, and we saw together, it's actually also the most common liver disease in people living with the IBD. So how we can prevent? As we have seen together that the main risk factors for this condition is actually metabolic risk factors, even in the setting of inflammatory bowel disease. I think that a healthy lifestyle, and for whatever it is possible, of course, to have regular exercise, to follow an appropriate diet, this would really help to reduce the risk for liver disease. On the other side, as there is also another condition with this inflammatory bowel disease in these people, in these patients, I think it is very important, would also affect positively the liver situation, and to avoid most of the liver problems, at least related to fatty liver, also to control, for what is possible, to control the inflammation around inflammatory bowel disease. So I also would like to ask, of course, Dr. Chen from the PSC part in terms of the risk factors. I know she mentioned already several, but I don't know if she has something to add to this.
Thank you, Dr. Stradia. And to take the lead, I just want to thank Megan for sharing a very touching story. It's a story that unfortunately I hear quite often from patients, and we try to do we do have a peer support group for our young adults within our system, and then we don't have a very systematic way for our more older patients. So just to go back to the question, what are risk factors of liver disease in Crohn's and colitis? Unfortunately, the fact that somebody has a diagnosis of IBD in itself is already a risk factor for PSC specifically. Statistically speaking, about 5 to 10% of the patients who live with IBD will eventually receive a diagnosis of autoimmune liver disease, and PSC being one of the really common ones. Up to date, we have not found any preventive measures that's very consistent in reducing the predicted risk for developing PSC.
Thank you. Lucy, could you advance to the next question, please? So this is about advocating for yourself, I guess. So how can I advocate for the link between liver disease and IBD with my healthcare provider? Dr. Chen, maybe you can start off. And Dr. Spaziani, I mean, it sounds to me maybe NAFLD is not very well known, so we'd certainly like to hear from you as well.
Okay. So I think if you're listening to the webinar, you're already taking the first step in advocating. It's very, it's a challenging situation because a lot of providers don't know much about IBD and liver disease. And I think by talking to your peers who may be also affected and suffering from similar conditions and coming to education sessions, joining patient support group are very helpful. PSC is really a very specific question that it's really your IBD doctors often it's the first step to think about, can my patient have a autoimmune liver condition that I need to look into? You have to rely on your provider who cares for IBD for this part, and you can always ask the question to your provider.
Dr. Spaziani?
Yes, I echo what Dr. Chen said. I think that for fatty liver disease specifically, since it is such a frequent condition and it is actually not as specialized as PSC, there is room for patients to actually advocate themselves with their primary care physician, even not even to go to the gastroenterology level of the one who is basically treating the IBD, but even at the primary care physician level, we're actually, as a Canadian NASH network, we are trying to do a lot of education at the primary care physician level, because this is such a frequent condition that primary care physicians should be involved, at least with this test that we saw together, simple test, some liver transaminases, platelets, do this calculation with the biomarker, this FIB4, and then refer to more specialistic tests. So I do think that for fatty liver disease, for just such frequent condition, and even in at-risk populations, especially in at-risk population like people with IBD, there is room for advocacy. There is room to ask the question, even to the primary care physician and of course to the gastroenterologist. Do you think I may have some risk for fatty liver disease? Do you have any suggestion? Do you have any? Because I'm telling you, more and more, this is actually a condition that primary care physicians are really seeing and are really interested in, because they affect so many of their patients.
Thank you, Dr. Sebastiani. Megan, I wonder if I could ask you to contribute to this question as well from a person diagnosed with the disease. It looks like you had a very proactive doctor who was suspected and had you go through the proper diagnostics, but I wonder whether there's life lessons learned in terms of your discussions that you hold with your physician in terms of just better managing your disease that you could talk about.
As far as managing my disease goes, during COVID, I had some issues with my liver disease that I didn't address. And I really wish that I would have pushed to see my GI, because who knows what progression the disease took, because I was too afraid to talk to my doctor about it. And I really wish that I had just been able to have that conversation with him and just say, hey, I'm not feeling good. Can I see you?
Thank you. So I guess the bottom line is try to get rid of your fear, and no matter what it is, be proactive and speak to your physician. After all, the physicians are there to help you.
Yep.
Okay, perfect. Thank you. Lucy, the next slide, please. Okay, so how many years does it typically take before a person with IBD develops liver disease or obtains abnormal liver tests? Dr. Sebastiani, maybe I can ask you to start this.
Yes, for sure. So for the PSC, I think Dr. Shen explicated very well the natural disease and the years that pass to develop PSC. For fatty liver disease, it's not very known, the natural history, so how this disease evolves or starts in people with IBD. We are just at the infancy of understanding the pathogenesis of the disease, so the story of this disease in people with IBD. But so we need more prospective studies, meaning people that are followed for years to understand. However, I can say that once fatty liver develops, which doesn't take much actually when there are some risk factors, it may take a few years actually to develop, to reach the stage of NASH and then of scarring. Usually we say that fibrosis or scarring develops at one stage every 7 years. So it may take actually several years, at least 20 years, to develop cirrhosis, so really the end stage disease. However, we don't know this progression in the context of IBD because we don't know really the story of the disease. That's why we need more studies. However, I would say that for fatty liver itself, so before going to the scarring in the liver, a few years with some risk factors are sufficient, a few years. So that's why when a population is considered at risk for fatty liver, this has to be addressed in a prompt fashion, not delay.
Great, thank you. And I know, Dr. Chen, you talked a bit about this, but anything else that you'd like to add?
Thank you. I just want to add on Dr. Sebastiani's comment. Yes, you could have IBD for PSC specifically. It could happen anytime during disease course, but once somebody has a diagnosis of PSC, the speed of liver scarring and inflammation happens a lot faster than having a fatty liver disease. So having a plumbing system of the liver, which is a bile duct that's inflamed intermittently or chronically, even in moderate or mild degree, tend to accumulate scars a lot faster than the fatty liver types. So for sure, it does not take 2 decades to damage a liver severely. It only has ongoing inflammation, much less than a fatty liver, which really speaks to the importance of early diagnosis and regular follow-up.
Thank you. We have a question from an audience member, and I'd like to go to that next before we advance to the next question on the slide. So this is specifically for you, Dr. Chen. Could you address the experience of bezafibrate for pruritus in Canada?
So the question is the use of bezafibrate for pruritus. It's a very popular agent in European countries. In North America, we do not have as much experience. It is on the typical pathway for control for pruritus. It is not considered first-line agent for most centers. Once we have already advanced liver disease, specifically cirrhosis of the liver, the safety of this class medication can potentially be an issue. So it's a lot more used with doctors who are European trained or in European major centers. But it is a common medication that's used for pruritus. That answers the question somehow.
Thank you. You know what? I have a question as well, and it's just something that confused me, or I was scratching my head on. Why is TPN a risk factor? Total parenteral nutrition. I don't remember, was it you, Dr. Sebastiani, or was it you, Dr. Chen, who mentioned that TPN could be a risk factor?
Yeah, I think it was me for fatty liver, actually. And this is really because, you know, with the TPN, you actually receive a quantity of hypercaloric kind of nutrition, you know, without a slow metabolization which happens actually with the food which is ingested through the stomach. And so there is also there are also a sort of all sorts of alterations. Also you don't pass the gut microbiota. There are multiple kind of etiologic factors. But actually what is interesting with TPN, with total parenteral nutrition, I think I read a question from in the chat about that. What is this? Is when you actually you are alimented parenterally, basically, is that the fatty liver can actually develop very fast compared to other risk factors for fatty liver, like obesity or diabetes. So we actually see patients that in a few months of total parenteral nutrition, they develop fatty liver disease. So this is considered one of the risk factors, specifically obviously in people with IBD, because total parenteral nutrition is used more than in the general population.
So can I just summarize what you said? So you talked about it might be because it doesn't go through the gut, and there's the microbiome there that might help further digest the foods. Am I concluding correctly that the TPN ingredients might require further digestion by the microbiome? So the way it's presented to the body is one that
like that is difficult.
Oh my. Yes. Okay. Thank you for that. Okay, Lucy, next slide, please. Okay, so what are the early signs and symptoms of developing liver disease that a person with IBD should watch out for?
Well, I can take that and then see also what Dr. Chen says. I think that, you know, the main, usually what is for fatty liver disease, actually for PSC, it's another story, and Dr. Chen will say, for fatty liver disease, we actually call this a silent killer, we call it, because it doesn't actually give symptoms until there is already cirrhosis in the liver. So, however, that's why it's very important awareness about the risk factors for the conditions, because there could be symptoms, but are very specific, like some patients actually for fatigue or lack of concentration, but there are not specific signs or symptoms that are related to fatty liver disease, only when there is cirrhosis developed. So when cirrhosis, there is more advanced kind of liver disease. So because of that, I think awareness of the at-risk population is essential, because then you can catch it earlier, the patients and also the treating physicians. And I think Dr. Chen can add for PSC, which is another story, a different story.
Yeah, thank you, Dr. Pisani. I agree. PSC is a chronic liver disease, and one of the slides we mentioned is up to 50% of the patient have no symptoms whatsoever at the time of diagnosis. So there are signs of PSC which are very specific to bile duct problems, such as itchy skin, yellowing of the skin with pruritus, and pain in the right upper quadrant. Those are really hinting towards typically larger bile duct problems, but not necessarily early signs per se. It really depends which part of the liver is affected. Again, routine blood tests to check for liver inflammation with the liver blood test is actually quite important to pick up early signs before the patient starts experiencing symptoms.
Great, thank you. I'm looking at the time. I believe the session was supposed to end at 8:30. So I wonder, and thank you to the audience for sticking around. We're 4 minutes after 8:30. So I wonder whether we could address 2 more questions and then conclude the session. So unfortunately to the audience members, we are unable to cover all the questions that you posed during registration, but we're more than happy to follow up and provide answers. So Lucy, could you go to the second last question? So that one the second last question is about asking how often should an individual have their liver enzymes checked? Dr. Chen?
Sure, I can take the lead. Thank you. So I think at least once a year, is, regardless of your, I really feel it should be just when people get screened for cholesterol and diabetes, it really should be once a year. When somebody has a diagnosis of IBD, they're certainly at increased risk for liver issues. For many reasons, they may have a reaction to the medication they're taking. So I think once a year is very reasonable as a starting point. And depending on the abnormality, if there's any, the follow-up tests can be followed up either a few months down the road. So the definition for chronic liver enzyme abnormality is over 6 months. At least twice a year, at least once a year, I think it's the bare minimum.
Dr. Sebastiani, anything to add to that?
Yes, when a patient with IBD, as any other patient basically is diagnosed with fatty liver, I totally agree with the once a year. I think especially for people with IBD is important. And if and when a patient with IBD is diagnosed with fatty liver disease, so usually we actually recommend to do a FIB4, this biomarker, which includes the liver test, the platelets, and the age every 2-3 years. So also to calculate this biomarker to make sure there is no fibrosis. So just that to be added to what Dr. Chen said, and in case also they can undergo a fibroscan as needed if this biomarker, this FIB4, may suggest that there might be some fibrosis, then they will also need to undergo this fibroscan, this ultrasound. Just these 2 things to add.
So I'd like to ask a follow-up question to that, and I'm not sure whether you know this, but Dr. Sebastiani, and I assume Dr. Chen, you work closely with gastroenterologists who specialize in IBD. Do you know if that's part of their regular practice to screen for liver enzymes once a year, or is this something that the patients should be advocating for?
Yes, I can take, but I would like also to know what Dr. Chen, what is her experience. So actually in our center, I have to say that the gastroenterologists that follow patients with the inflammatory bowel disease, they actually ask regularly, at least for an ALT. An ALT at least is regularly asked for, and also the platelets. The AST, the other liver transaminases, may need maybe to be added sometimes, but the platelets and one of the transaminases are regularly asked. I don't know, Tienya, you have other...
I concur. We work in the same center, so we do have a separate IBD center, which follows a large population, and it is their routine testing. They refer patients regularly.
That's great. That's reassuring to know. All right, we're going to go to the next question, and then after that, we're going to conclude. So the question is, does having an ileostomy and no gallbladder put you at a greater risk of developing liver disease?
Well, I'll just go ahead and comment on the PSC part. I'll let you comment on the fatty liver part. So for the PSC, which is the rare autoimmune liver disease, it really doesn't really matter how your IBD is doing, whether you need a colostomy or not. The fact you do not have a gallbladder anymore definitely eliminates the risk of gallbladder cancer from that perspective. But in terms of complications related to PSC or diagnosis of PSC, I don't think it necessarily altered the risk. So I'll let Dr. Sebastiani comment on the risk of fatty liver.
Yes, thank you. So actually, there are some, the ileostomy for the gallbladder, there is not a clear association actually with fatty liver if there is no gallbladder. However, for the ileostomy, I have something more to say. Not itself the ileostomy, but when a patient had undergo, for example, for the ileostomy, had undergo resection or surgeries or something related to the to an activity of IBD more intense, let's say. Actually, our studies so far, and I also found other research groups suggested the same. So an active IBD and surgeries related to IBD actually have been associated by our data and also some other researchers to a higher risk of fatty liver disease.
That's great. So that was the last question. Unfortunately, I wish we had more time so we could ask you more, but we don't. So as indicated, we will be happy to follow up with any of the audience members if they have any follow-up questions and provide the answers. I'm sure Dr. Sebastiani Chen, if there are questions that we feel that you haven't covered, we would pass it on to you, and that's wonderful. Thank you. So thank you to the audience members. Thank you to our panelists, first and foremost. Thank you so much for making time. I feel like I need to say a special thank you to you, Megan. Like I said, your personal story really touched me. And every time I hear from someone who's diagnosed with IBD, I learn so much more. And it does put that human touch, if you will, on a disease. So thank you for that. And thank you, of course, to Dr. Sebastiani Chen for making your time in an area which, as you said, there isn't much known in IBD. So really valuable session. I certainly learned a lot. For those in the audience who have more questions or require further support, please contact us. You can email us via learn@crohnsandcolitis.ca, or if you'd like to contact the Liver Foundation, you can contact them directly at clf@liver.ca. Merci beaucoup, everyone.
Thank you.
And it looks like there's a poll question. Okay, so for those who are still remaining, this is really just a sense as to whether you learned anything from the session. So we'd love to understand whether you learned anything from the session based on the panelist presentation. So if you could just make a little bit of time and respond to these questions, that would be wonderful. Okay, fabulous. I think we had a lot of ones and twos as well at the beginning, and I see that that level has increased. So that suggests that the audience members have learned something today. So thank you so much to the panelists, and thank you to the audience members. And as usual, we always send out a survey after to hear from you directly on what you thought about this session. If you have any suggestions for future sessions, please do let us know, because that's how we identify what topics we will be covering in future Gutsy Learning series. So thank you to everyone again. Special thank you, of course, to BG Communications, who offer live communication, our live French translation. So thank you to Mike. And thank you to, I know we have a new member today who's helping Mike with the translations. So thank you to Carolyn for that as well. So follow us on social media if you have social media channels. And with that, I'd like to thank everyone again and enjoy your evening. Thank you.